Yeah, right now you can hear me, right?
We're there. We can hear each other.
Right.
Hi, Professor.
Hello, how are you?
Okay, thank you. How are you?
I'm fine, great, thank you.
You've had a busy clinic.
Yeah, I just finished my clinic right now,
Oh,
and
well,
I'm
thank
ready,
you
but
very
I'm
much for
sorry,
your
I'm
time.
just ready for just 15 minutes. So can we make quick questions and then we can have another meeting like after 1 week, okay?
Of course, no problem. So if
All
you'd
right.
like to introduce yourself, Professor.
Yeah, I'm Professor Abouzeid. I'm a university professor. Since 2019, I'm a university full professor. Before that, I was assistant professor. I work in bariatric surgery right now for 15 years, from 2007 till today. I have my perfect health clinic. As you can see here, this is my clinic. If you can see it right
Yeah,
now, this is my room, and we have other three rooms in our clinic. We work in a big center, the HCC Center right now in New Cairo. It's in the center of New Cairo, which is the modern Cairo.
okay.
And we have the hospital here in the same building. We have the big X-ray and ultrasound and MRI and CT unit here. We have the big lab. We have the ICU. Everything in one building.
Everything you
It's a
need.
very nice building. And if you can see from here, if you can see this compound behind us is where our hotel resides. We have a contract with the hotel back there to have our patients moving from the hospital here to the hotel. We started our foreign exchange, foreign patient program like 10 years ago, but it was for the Gulf area. We were satisfied with our patients from the Gulf area because they were just taking a flight 1 hour and
Mhm.
come to us. We started our UK program since the start of the COVID era because some patients from UK seek another centers beside Turkey because Turkey was closing the borders. We found that a lot of patients sending to us and asking for a program for the UK patients. So we started the UK program for the UK patients 2 years ago. I'm GMC registered. I have a full GMC registration since 2007, and I worked as clinical attachment when I was young in UK. But since I started my career here in Cairo, like 2005, I didn't work in UK from that time because I'm busy all the time.
Yeah, of course.
Usually, our patients come to us from UK. They stay for 1 night pre-operative. They do the lab investigation. They stay another 2 nights in the hospital for the operation. They usually arrive at 9 p.m. from Heathrow to Cairo direct. We are just 15 minutes from the airport, so they just have the night at the hospital. I meet them. They have the lab tests,
Yeah.
and then they have the operation. They stay for the operation 2 nights in the hospital to make sure everything is perfect, and then they move for another 2 days in the hotel, and then after 4 days they can return back to UK safely and for follow up on the WhatsApp. So this is about our practice and how we do our practice with the UK patients.
That's fantastic. That's really good information for us to know in the UK. Now, I'm just going to go through a few quick questions because obviously from a professor side of things, all my sort of group people would like to know a few questions, if that's okay, if you could answer a few.
Sure.
For instance, what's the difference between all the bariatrics procedures? Which one would you sort of recommend for?
Okay. Basically, there is no gold standard for one patient. Okay, for each patient, there is the gold standard for this patient. Okay, if you can see here, here's the biggest book about the one anastomosis gastric bypass, which is growing fast, and I'm one of the leading surgeons in the world for the one anastomosis gastric bypass, or the what we call mini gastric bypass.
Okay.
This is one of the uprising and gaining lot of popularity all over the world. The one anastomosis or gastric or one anastomosis or mini gastric bypass, and it's taking the upper hand in Egypt here from the classic gastric bypass. Okay, but still, I don't offer the mini gastric or one anastomosis gastric bypass for all my patients because we have some young patients who have like 18 years, BMI 35, and sleep is more than enough for them. Okay, so we choose the operation for the patients according to the criteria of the patients, what he eats, his BMI, his comorbidities. I mean that if the patient has like diabetes and type 2 diabetes with lots of units of insulin per day, I would go for the mini gastric bypass or one anastomosis gastric bypass. If the patient has severe reflux, I would go for the classic gastric bypass. If the patient had a band before, and lots of UK patients that come to our center had a band before. We remove the band and then we do the mini gastric bypass. So we choose the operation and the procedure according to the patient. Some patients only need balloon, but this is
Yes.
very, very, very few patients who need only just the balloon. But
With a little bit of weight.
still they are present. So I'm not the kind of surgeon who will just say that only sleep or only gastric bypass or only. We have to choose the operation according to the need of the patient. And even some patients coming from UK to my clinic here, I sit in front of me and ask me about, and we were settled about, for example, the mini gastric bypass. And after sitting with the patient, I would tell her, no, it's better for you to have a sleep. Based on just one thing in the history that she didn't mean. Some patients have some kind of collagen diseases and they need corticosteroids. So on the long term, they can have ulcer on the anastomosis and it's safer for them to have a sleep. So basically, it's very, 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 very patient-based selection, and we need to select the patients according to his situation.
That makes sense. That makes sense. Yes. Yeah. Okay. Just quickly then, does the sleeve? Well, how much weight can you expect to lose after surgery?
Our target usually is that the patient reaches the ideal weight, but scientifically, each operation has a capability. For example, what is written in literature that after the mini gastric bypass, you can lose up to 80 to 90% of your excess weight weight. And for sleeve, it's like 70 to 80% of the excess weight. So if we reach that, if you had, like, for example, if you are having like 40 kilograms excess weight and you lose 30, this is perfect for operation, okay? But this is not usually our target as surgeons. Our target is that I know the capability of the operation, but I'm working on the capability of the patient also. You have to know that eating healthy food will make you lose more weight. You have to know, I'm sorry, are we still on the...
We are, yeah.
Okay, because your picture is not moving right now. So,
okay,
so I mean that usually our target is the ideal weight. Some patients with super obesity, they can't reach the ideal weight. I can say that some patients has like 220 kilograms. This is huge. And the ideal weight for them is 70. And they can't reach it. They can't lose 150 kilograms. They can't, because they can lose like 120 kilograms and then they stop at 100 kilograms, and that's perfect for them. After removing the excess skin, they can lose more weight, because the excess skin usually in this kind of patient is a lot, and removing the excess skin will give them a boost. And after removing the excess skin, they can have more sports and more healthy food, and then they can reach another target.
So but will they have to do more skin removal after they've lost more weight?
Yes, but usually we prefer that you do the skin removal once. I mean that we have, for example, if you are 180 kilograms and our target is 80, and then you reach the 100 and you stopped, then we can say that now you stopped, we can remove the excess skin. Even after you remove the skin, you don't need to remove another skin. So usually it's just one step to remove the excess skin. And not all the patients need to remove the excess skin.
No.
Some patients are 140 and 150 kilograms, and with the sports and with some topical creams, they don't need to do more than that, okay? So not all the patients need to remove the excess skin. And some operations like the arms and the thighs are usually not necessary in most of the patients. The usual and the more common is the belly or the excess skin of the abdomen, because most of the patients has redundant skin and they want to use the...
That's my arms.
Yeah, for the arms and thighs, some patients usually only need sports and some topical creams.
Okay, I've had the revision, and I feel from my sleeve to my sleeve, I lost 10 stone, and
what was your
385 pounds,
which is
27 stone.
27 stones. Okay, so you lost, after the 27 stones, you lost 10 stones, and then you stopped.
And then now I've stopped, so I went to revision.
So you went to plastic bypass or one as was a
gastric bypass? RNY.
RNY gastric bypass. All right.
Yes.
And
I've only lost 2 stone.
Yeah. For me, if you came to me with sleeve and failed, I would do the one anastomosis gastric bypass, not the classic bypass, because you will lose more with the one anastomosis bypass. It's my opinion, okay? I know that.
I feel my stomach's bigger.
Yeah, your stomach maybe is still bigger. I can't judge you right
Obviously.
now without having a dye study with me. We usually,
of course,
our approach to redo patients is that usually the patient comes to us after a sleeve and he says that I don't lose weight. Okay. So I have to assess the patient if he is not losing weight because he is eating wrong food or he is eating a lot of food. Okay. If the patient is eating lots of food after the sleeve, this means that he has a very wide sleeve. Okay. So we need to remove a lot of the stomach again. Okay. We usually remove another half of the remnant stomach and then do the bypass. Okay. Or the patient still have a very good sleeve, but he only eats sweets. And at that instant, we can just placate or make it the stomach a bit smaller and then do the bypass. But in my opinion, after that, we need to do one of two things. Either one anastomosis gastric bypass, or if the patient has a very, very bad reflux, we can have the Roux-en-Y gastric bypass, but with the configuration of the one anastomosis, meaning that the biliary limb is long. And this is what we learned from the experience over 15 years, that when you do the classic bypass, the very classic bypass after the sleep, the patient usually don't lose a lot of weight because he needs to have more malabsorption after this.
I feel personally that I can eat more, and I'm worried I've stretched it. I have gone to the wrong foods mentally. I don't know why. My sleeve, perfect, did everything I was told. For the bypass, I don't know why I've sort of gone off track. But people do that.
I think you can't eat like quarter of whole chicken. Quarter of the whole chicken. I think you can. Can you eat quarter of whole chicken?
I can. I can eat the whole chicken. A whole
can eat the whole chicken. Oh, so.
And I have been since I had the operation. As soon as I went on solids, I could eat more than I was on the sleeve.
Let's say that most of the patients after the sleeve can eat more with the bypass. This is basic because right now you have the food moving fast from the stomach to the intestine. So most of the patients can eat more. So it's not a problem of you. This is the usual, and this is for every patient. Because after having the restriction of the sleep, right now you are having food moving fast from your stomach to the bypass. And all my patients after the band to bypass, they say that I can eat a lot more after the band to bypass. So this is usual. But still, I can't assess your stomach without our virtual gastroscopy. We do
it was just interesting to see if it can be stretched.
It's called virtual gastroscopy with stomach volumetry. Based on this stomach volumetry, we do it with a CT scan and we do a reconstruction of the stomach, and then we can tell you exactly what's the size of your stomach and if you need to downsize your stomach or it's just the food moving from stomach to your.
So when you've had the revision, can you still have more surgery on your stomach to make it smaller?
Yes. If it's big stomach, we can do it. We can make smaller and we can put a small ring. It's called minimizer after the classic bypass.
Okay. And so what else was I going to ask? So what else did everybody want to know? Like things like how can they prevent regaining weight after surgery? Why do people sort of have the gallstones after? Sort of the gallstones play up after?
Okay, first, sleeve is not a universal technique all over the world. I mean that my sleeve is different from the other surgeon's sleeve, okay?
Of course.
So I would speak about my sleeve, okay?
Of course.
If you have my sleeve, I call it good sleeve because with my sleeve, I make sure that we don't have kinks, we don't have twists, we don't have a narrow area in the sleeve. Why? To let the patient eat quarter of what he eats before the operation, like 25% of what he eats before the operation. And this 25% have to be proteins, vegetables, fruits, and some rice or pasta
Yeah.
or brown bread. If you need to make sure that you don't gain weight again after sleep and reach the ideal weight, you need to eat only this. You have to stay completely away from any kind of white sugar, any kind of sweets, any kind of white wheat, any kind of bakeries with white wheat and
Mhm.
pizza, all kind of fatty cheeses, all kind of fizzy drinks except sparkling water. Cut as much as you can from alcohol because alcohol has a lot of calories, especially alcohol and cheese. It's very, very, very liable. The patient with that is very liable to have weight regain, and of course the crackers. Okay, so if you have the operation, stay away from this. Okay, and if you have a good sleep, you don't have the tendency to have reflux because you are having the food moving from your esophagus to your stomach to your intestine. So the incidence of reflux is very rare, which is different from the concept in UK that after sleep you'll have definitely reflux. You won't
Yeah.
have reflux, and it is completely different from the concept that you have to vomit after eating more. Most of my patients, if you ask any of my patients on the group, they will tell you that we don't vomit because the basic thing is that you'll have this kind of sleep that I usually tell the patient that you will have this. This is the good sleep or the kind of sleep that
Yeah.
you should have, which is food moving in very, very uniform tube from the esophagus till the intestine. Okay.
Okay.
What I see after many of the surgeons, they have kinks, they have twists, they have narrow areas, and or they have very tight sleep, and this will eventually lead the patient to eat more sweets and become sweet eater, and then he will need definitely bypass.
Okay. Now,
I'm
can the
sorry,
stomach stretch?
I have to tell you that I still have only 7 minutes. Okay.
Okay, sorry. Can the stomach stretch if you do
No,
eat all the sweets and everything?
no, you will
Okay.
get that. But the stomach usually doesn't stretch except the normal stretching, which is the thing we need. Usually, if you have a good sleep, the stomach will be like 80% less. So you'll have like 20-25% left. And if we have an X-ray, the virtual gastroscopy with stomach volumetry that I'm talking about, if you have it like 5 years after the operation, you'll just have excess 5% only increase. So the false idea with the patient that if we drink fizzy drinks that will stretch our stomach, it's not right. If you have fizzy drinks, you will get fat because they make you fat, not because that
Okay.
your stomach.
It's the calories.
It's calories. No, it's not about the calories because you will say that, okay, I'll drink Pepsi Zero or Coke Zero, which has 0 calories. It's not
Mm.
about the calories. It's about the thing. The Pepsi and all the fizzy drinks have the thing that makes you fat. It's not about only calories.
Okay.
It's a formula and it's a combination of things that will lead you to have fat, to be fat, even if you drink Diet Coke. Okay? So
Okay.
we told the patient it's not about making your stomach bigger, it's about making yourself fat. Because most of our obese patients before the operation are drinking Diet Coke or Diet Pepsi and still they are fat. Okay?
Okay. Now, sorry, just bear with me a moment. Mental health, after the surgery, can you get depression or mental health problems?
Yes. If your surgeon doesn't tell you before the operation that you have to change the kind of thinking you have and that your love of food will stay the same, but you have to concentrate on or think on things that other than food. Because some patients, all their lives are rotating around food. Okay. So if they cut the amount of food, they will have depression. Okay. So we are preparing the patient. You're having good food, you will eat good food, but you stay away from bad food, and you must have more activities in your life. If you are ready for that, I think you won't have depression. Most of the patients are not ready for that, and that's why they have depression after the operation.
Okay. All right. Well, look, thank you very much for your time. I know you've got to go.
Yes.
I was going to, how much is it to come to you and have consultations?
Okay. For the online consultations, I'll do it for free. Okay. For UK patients, I do it for free. It's not a problem. If I have time, I'll just stay with the patient and have a consultation even for half an hour. It's not a problem at all,
Okay.
as long as it's in my free time.
Okay.
It's about consultation, but it's for the operation. We usually have the program, the full program. The full program ranges from 3,000 sterling pounds up to 4,800 sterling pounds. It depends on what we're gonna do to the patients. Some
Okay.
patients have big complications before and they need big redo surgeries, and this will put them in the category of 4,800, which is a maximum here for the full program, the 5 days program. But with the other programs, like if they are having straightforward sleeve, it will be starting from 3,000 sterling pounds for the full program.
Okay. And if I was to, for me personally, if I was to come to you and literally just have, because I've had the revision, and if I want to look to see how the stomach is and to make it a good revision with you, how much would that cost?
I can't tell you because till now I don't know how many meters did you bypass in the first place and the size of your stomach. Because you can come to Egypt and then I can find that I can do nothing for you. And then I will tell you, go back to UK without doing anything.
Yeah.
So I can say with online consultation like that, in your case, if you can do anything more or not. But I can tell you that in some patients, like your case, we make the stomach smaller and put a minimizer. If we do this procedure, it usually the food program costs about like 3,800 sterling pounds.
Okay.
But we can do it because some patients have very, very small stomach and they don't need anything from us. You just need to stop eating unhealthy food and go to the healthy food. So we need to assess your stomach. So we will need you to come to Egypt early and to Cairo early to make you the investigations. And it takes like 1 day. And then we'll tell you that you can do the operation or you don't need anything. Okay?
Don't need it.
So you have to be ready that you will come to Egypt because to do this kind of virtual gastroscopy stomach volumetry in UK, it's very, very difficult because few centers have it, and you have to reserve it very, very like 3 or 4 months before. And most of the patients usually try to find it and they can do it. So it's easier to come and have the full investigation. And if you have it, if you can have the operation, we will do it for you.
Okay. All right, my love. Thank you so much for your time today. Really appreciate it. And I'll be in touch. Take care. Bye-bye. Bye-bye.